Hi there. We are going to talk a little bit about the nursing care of the newborn with special needs acquired in congenital conditions. For my live course, there's just a couple of the disease processes here that we really are covering. But for those of you that are interested in working in the NICU or in the PICU or any of the intensive care areas that deal with newborns and pediatrics, this might be useful to you. We have discussed some of these conditions in other places, but we're just going to discuss them a little bit more in depth here. So, items that affect fetal growth can be maternal nutrition, both for excess fetal growth and not enough fetal growth. Genetics, if you were 8 or 9 or 10 pounds when you were born, or your partner is, then it's more likely that you're going to have a baby that is similar to what you were born. How well the placenta is functioning, and that's going to depend on things like, did you have a COVID infection while you were pregnant? We see lots of placenta issues with the COVID-19 virus. Did you have hypertension in pregnancy? Those will affect fetal growth as well. And then environmental factors like exposures to toxins or teratogens, as they're called, or cigarette smoking or pesticides. So lots of things can affect the fetal growth. We have birth weight variations. So appropriate for gestational age is about 80% of newborns, small for gestational age, and large for gestational age. So again, different disease processes are going to cause each of these things to happen. And then we have birth weight categories. We have a low birth weight infant, which is less than 2,500 grams or 2.5 kilos or 5.5 pounds, or a very low birth weight, which is less than 1,500 grams, or extremely low birth weight, which is less than 1,000 grams at birth. And these are all babies that will be in neonatal intensive care and need lots of assistance to get to the point where they're going to be able to function independently as a newborn. So here are just some pictures of the different classifications. This picture is, I think this is supposed to be average for gestational age, low for gestational age, and large. And then this is that classic newborn frog-like posture. You'll see it described as that, where this is the premature newborn, and they just don't have the musculature. You see how this baby is flexed, and this baby is not quite as flexed, and this baby doesn't have the muscle control. It's that frog-like posture of the premature infant. So our small for gestational age babies, less than 28 weeks, and if they're born less than 28 weeks, they will probably never catch up in size. But if they're greater than 28 weeks and they had intrauterine malnutrition, they can catch up with good postnatal nutrition. So small for gestational age newborns, these might be, again, infection, hypertension, anything that decreases the flow to the fetus. IUGR, when we're looking at intrauterine growth restriction, we're looking at asymmetric versus symmetric. So we really want the brain to get as much as possible. So we prefer to see the asymmetric, where the head is much larger than the body, versus everything was restricted. And then if you are following along in the textbook, the Ricci book, the contributing factors to these conditions are in box 23.1. So our characteristics of our small for gestational age baby is the head hopefully is disproportionately large, because again, we want the brain to have gotten everything it needed. And then they might have a wasted skin appearance or loose, dry skin, reduced subcutaneous fat. They might have a sunken appearance in their abdomen and very wide skull sutures, poor muscle tone over their buttocks and cheeks, which means that they're not going to be as efficient when they feed, and they might have a very thin umbilical cord. Common issues that we see: polycythemia, that's all those excess red blood cells that will in turn increase the chance for hyperbilirubinemia. Meconium aspiration might be there, hypoglycemia, difficulty with thermoregulation because they have even less fat than our other babies. There might have been some asphyxia, not enough oxygen during delivery or during birth, pregnancy, and birth trauma. So the things we're going to be doing for these small for gestational age newborns, and this is a good portion of what you will see. Well, this is a portion of the patient population you will see in NICU, is we're going to be watching the glucose monitoring very closely. We're going to be watching their weight, length, and head circumference measurements to chart and plot that growth. Vital signs are very frequent. Maybe oral feedings and possibly some D10 or some TPN feedings. And anticipatory guidance for the parents. These babies are going to need some time in the NICU to catch up to where they need to be, and they grow very quickly once they get out. With our little ones, they aren't able to sometimes take in all the nutrition they need before they tire out. So we might have to supplement them with IV or tube feedings, which is feeding either a nasogastric tube or an oral gastric tube. And so they'll need a little bit of time, but typically they're feisty and they do very well. Our risk factors associated with our large for gestational age babies is, these are risk factors to make a large for gestational age baby is maternal diabetes, again, or glucose intolerance, multiparity, a history of a macrosomic infant, macrosomia being large for gestational age, post-dates, maternal obesity, you have a higher risk, a male fetus, and sometimes just genetics. Some people just grow really large babies. So they have a large body, plump, full-faced. They are proportional. Sometimes they have poor motor skills, so they can also be poor feeders because they don't have the muscular capability to keep up. And sometimes they have respiratory distress because, again, they don't have the muscular capability to manage their body size. And so this is one of our large for gestational age babies that obviously is being fed with an IV and potentially a NG tube, is on oxygen support, and is going to need a lot of help to wait for those, I'm assuming, the insulin production to come down so that they are not experiencing hypoglycemia. So we see birth trauma. These are our babies that have a hard time getting out sometimes, especially through the birth canal, the hypoglycemia, polycythemia, and hyperbilirubinemia. Interestingly enough, though, if they're late post-term or post-dates, their livers are typically more mature, and we don't see as many issues with hyperbilirubinemia, but they can if their moms had diabetes, because again, that's where that blood sugar sets up, is on that red blood cell. So same thing, vital sign monitoring. One of the reasons these babies really need to be in a NICU high risk setting is because then they are assigned a nurse just to them, and we have monitoring equipment that is continuous. So we don't have that ability to do that behind a closed door on a regular floor, and that's why these babies need to go to a higher level of care. They also might have IV glucose and or D10 or TPN, and we're going to be watching for those signs of hypoglycemia, polycythemia. So here's a gestational age variations. Anything term is, according to your book, 38 weeks to 42 weeks. Preterm is before 37 weeks. And then we have this whole area of late preterm. We didn't really talk about this in the other lecture, but these are the babies that will be at bedside. They almost always, well, unless they have another issue, they're not going to go straight to the NICU or nursery just because they're late preterm. But they have a lot of the same problems that we see in our preterm babies. And we're going to talk more about that. And then our 42 weeks. So post-term newborn, this is the baby that was in after 42 weeks. And sometimes we can see this dry, cracked, wrinkled skin, maybe meconium, because they didn't have the vernix there. They will have creases over the entire soles of their feet. They might have a lot of hair, a very thin umbilical cord, and that reduced vernix and lanugo. So here's a picture of what a post-term baby might look like. Cracked skin, a little bit of meconium staining potentially. This is going to be fine. We don't have to do anything special to this in the neonatal period. And then this baby creases over the entire foot. So again, those post-term problems, we might see meconium aspiration. We are concerned about that. Oftentimes they do just fine. It was prenatally that we were more concerned with that higher risk of fetal loss in that post-term time period. But once we get them out, they usually do pretty well. So here is our nursing management of those post-term babies. And then preterm. Preterm is really more common than I think is talked about in our society. We know that there is some etiology, some things that lead to preterm: infections, inflammation, maternal or fetal distress, if there's been bleeding because maybe we have placenta previa or placental abruption, or if there's been trauma to the uterus and there's bleeding. And then that stretching of that uterus, especially if there's multiples, because they get to that larger size faster, that can lead to preterm labor and then preterm birth. So in our preterm babies, their body systems are immature. And so that really affects how they transition from intrauterine life to extrauterine life. So oftentimes they'll need to go into something that looks like this. This is called an isolette, or old term is an incubator. And this isolette is really going to mimic the womb. And so it will have a soft place to lay. We use all sorts of devices to help support the infant as we're moving them around, because their bone structure is very soft and moldable, and we don't want to cause any deformities to that by movement or by laying in one position for a long time. We also oftentimes will cover this up so that they have periods of darkness. It will control temperature. It will control moisture in some cases. And these will be on a monitor. The babies will be on a monitor, so we'll be able to visualize their vital signs even when we can't visually see them. But their immune system and their nervous system and all their major body systems are even more immature than a newborn. And so we have to support all of those. So some of the characteristics we might see: poor muscle tone. They might have undescended testes. In some cases, if they're very early, they might have fused eyelids still. Plentiful lanugo, that soft hair that is on their bodies. Absent to few creases in their soles. Very thin, transparent skin. Soft, spongy skull bones. So lots of differences in our preterm characteristics. And here's some pictures. Here's a baby that has no creases on the soles of its foot. You can tell that is a very premature baby. And you can see by their size that they look different than a full-term newborn. This one is getting respiratory support. It's being fed, gavage fed. It has IV support. It's in an isolette, which is going to control its temperature and possibly even moisture. And then it has a continuous O2 sat. These are leads to give us respiratory rate and heart rate. So this baby is in an intensive care situation. Again, some of those little feet that are uncreased. Here's another little one. You can see that thin skin where the vessels are very much apparent. A hat to keep them warm. Here's another little one that's reflexes are just responding to being picked up. And here's another one that is getting some CPAP. And these little, there's a mask that goes over the nose and prongs that go in the nose. And we have to actually change them out every 4 hours, or depending on your policy, because these can deform the shape of their nostrils. So they are very, very soft and fragile. So some of the problems we see with our preterm, the same problems we've been talking about: hypothermia, hypoglycemia, hyperbilirubinemia, and then immune system issues. So our management here is always airway, breathing, circulation. We have to manage the oxygen, and that will be determined by the provider, what kind of oxygen support we will use. And we want to use it for the smallest amount of time as possible. The oxygen that we give these premature babies actually can, if the long-term high dose oxygen can affect their eyes and their eye development, and that can cause them to have other conditions, searching for the word, retinopathy of prematurity. And so they might have, that might contribute to having to need other procedures to help the growth of the eye. And it's actually on the retina in the back. We will have to control the nutrition and fluid, and there's a very small window of that balance. In fact, they will do labs most every day and check that against what they're getting as far as their solutions, and that will be ordered every day. Obvious infection prevention. These are our most fragile patients. And so this is why the NICU has to be such a closed environment, in that we can't just let a lot of students in, we can't let a lot of visitors in, because we have to control the infection. If these little babies acquire infection, they often don't survive it. So it's literally a life and death situation. And we want to decrease the stimulation. These babies' brains are not ready for the same interactions that a newborn would be ready for. And so we decrease the stimulation. We don't, when we're holding these babies, we aren't rocking back and forth or swaying like, we're programmed to do. We don't tap on the glass. We don't pick them up and handle them all the time. They have long periods of sleep and rest so that they can grow. And we have to educate our parents about that too, because they wouldn't be expected to know that about a premature baby. And feedings. So feedings will come either, some nippling may happen, or breastfeeding, but we have to manage how much goes in, because remember, there's that very delicate balance. And so they will get feedings either in something that looks like this, or sometimes the syringe pump will be connected. A syringe will be connected to a syringe pump. And this is a NG tube, and it will be checked every time for placement to make sure that it's in the correct place, or sometimes you'll see oral gastric tubes. And this allows them to get the nutrition they need to continue the growth process without using the energy of nippling. Sometimes, like I said, they can't take in as much energy as they need for growth and for calories. So we have to supplement them until they are ready to take in what they need. They get too tired from the nippling. So discharge planning looks different when you're coming from an intensive care unit. And so we want to make sure that the parents have lots of involvement in the care of the newborn while it's in the NICU, and then support once they go home. There'll be lots of different things that they'll need to do. They won't just have well baby visits, and most likely have high risk baby visits, and some other things like I mentioned about the eye exam for the ROP, and maybe even some other early interventions to help these babies reach the best of their potential. So our late preterm baby, this is really a challenge because they don't really meet the criteria to need to be in the NICU all the time, but they're not like a normal newborn. And we, as the nursing team out on the floor, really need to be watching them closely. And so we will be watching for hypothermia. We will be watching for signs of hypoglycemia, watching for signs of respiratory distress, watching for signs of early infection, early cues of that infection. And talking about perinatal loss, unfortunately, NICU and PICU are areas that you will see perinatal loss as well. I mentioned it in labor and delivery. That's something that we deal with when we have our fetal loss. But any loss up to 1 month old is considered a neonatal death, 28 days. And it is obviously a profound experience for everyone involved. And we want to make sure that we are getting our grief team, our loss team involved, because these parents will need ongoing support once they leave us. And we need to have a safe outlet to discuss these things with, because this is the hardest of the hard. This is the part of our work that can affect our personal lives as well. And we need to have a good self-care routine, and also have ways maybe a trusted therapist or trusted friend that we can discuss these things and debrief with our unit about. So now moving on to chapter 24, I'm going to briefly talk about a few of our acquired and congenital conditions. And throughout the re-recording of all these videos, I'm working really hard to change some of the language that I use to make it more inclusive. And so instead of saying defect or disorder, we're really trying to change that to different, so acquired disorders and congenital differences. And so anything that is acquired, it typically occurs at or soon after birth. And these are problems or conditions maybe with the pregnancy or the birth specifically. And sometimes there's no identifiable cause. For instance, an acquired condition would be infection. But a congenital disorder is present at birth. And it's usually due to some sort of malformation or genetic difference. And so this is something that they were born with that they're going to continue to deal with throughout their life. So some of the acquired conditions are listed here on the screen. I'm not going to read all of them to you, but just to talk about a few of them. When we're talking about asphyxia, we're talking about not enough oxygen. And then we have our PVH, peri or intraventricular hemorrhages that can happen in our premature babies, our extreme low birth weight babies. We have necrotizing enterocolitis that's often abbreviated as NEC, and this is a condition where the bowel does not receive enough oxygen, and there actually can be portions of the bowel that die. And this is a NICU disease process that we typically see within the first few weeks of life. And then there is newborns of perinatal substance abuse. And we're going to talk more about how we can deal with those as nurses in just a minute. So then HIE, hypoxic ischemic encephalopathy, is the disease process that occurs when asphyxia has happened. So there's not enough oxygen either during pregnancy or at birth or right after birth, and it's insufficient oxygen to meet metabolic demand. So this is the term that we are looking at that really is a diagnosis that comes later on when there is other problems that have happened. So we might see babies that develop cerebral palsy or babies that develop other impairments, and it can be related back to their birth experiences. And so some of the things we're on the lookout for early on for this is newborn's color at delivery and shortly after, what their vital signs were, what their APGAR scores were, and especially if they had seizure activity very soon after delivery, those are warning signs that we could have developed hypoxic ischemic encephalopathy. This is one of the reasons that you might hear of a baby being sent out or maybe going to the NICU for cooling. That's one of the nursing interventions, medical interventions that we will do if there's been swelling in the brain when it's been deprived of oxygen, and that's to try to prevent this disease process. Transient tachypnea of the newborn, I've mentioned this before. We really should see resolution by 72 hours of age. And we might see some of the grunting and retracting and labored breathing and nasal flaring that we mentioned before, but it should be transient and it should be short-lived. If not, these babies are going to have to go to the NICU for further treatment, maybe antibiotic therapy, maybe postnatal surfactant, up to the provider there. But we can't let this continue forever because these babies will get tired. And again, nursing management is the same. We're going to be watching them very closely. If they don't transition out of this very quickly, then they're going to need to go to the NICU and have their own nurse taking care of them. So respiratory distress syndrome is the condition that can happen with our premature babies or any baby that is having infection or other issues. We might see respiratory distress. And this is lung immaturity because of the lack of that alveolar surfactant that I mentioned before. So we give these moms, if we know preterm birth is imminent, we give these moms a dose of either betamethasone or dexamethasone. And then 12 or 24 hours later, depending on which kind we gave, we'll give it again. And that's to increase the surfactant in the newborn. So it's not for the mom that we're giving her the medicine, it's for the baby. But these are signs: nasal flaring, retractions, seesaw respiration, central cyanosis, and then our chest x-ray is going to tell us for sure that we have this issue. So there's a scoring system that we can utilize for respiratory distress syndrome, and you can take a look at this here, and that will let you know how marked it is. Here are some of the treatments that we might use for respiratory distress syndrome: is oxygen therapy to help that oxygen exchange, increase the oxygen molecule that is there. So this is a CPAP, this is a high flow nasal cannula, and this is the traditional tube that they would use for intubation. Meconium aspiration syndrome, I've mentioned it a couple of times. This is when newborns inhale the particulate meconium during delivery or after rupture of membranes, and it can cause, it acts kind of like glue in the windpipe, and so we don't want them to have a big, thick breathe in of this meconium, because then it's going to not allow that oxygen exchange, similar into ways that it does with the premature baby, except that it's not a surfactant issue, it's mechanical blockage. And then other NICU conditions I've already mentioned, but I want to focus on substance abuse. So when we are looking at substance abuse, we know that these babies have a umbilical cord that is going to provide them with a lot of the same things that are circulating in the mom's system. And unfortunately, the placenta allows quite a few drugs through. And these babies become addicted as well. And so there's lots of work on developing a way of managing these babies. And some places are staying up with the evidence base, and some places are not. And so we know that these babies are going to have to withdraw from the medications that they have become accustomed to. And we see things like our narcotics are highly addictive, tobacco is highly addictive, alcohol is highly addictive. Some of our prescription drugs like Xanax, highly addictive to these babies. So we want to have them in a stimuli reduced area, and the lights and bells and whistles of the NICU can be very, have a lot of stimulus in them. So oftentimes they're moved to an area of the NICU where they can have a less stimulus in the environment. We want to talk about with the parents about the interactions and how they're going to soothe these babies, and obviously use shared decision making in treating these babies. Now, this can be kind of a touchy subject because the mother may be withdrawing herself, or she may have gone back to using and won't be having withdrawals, but yet her baby is. So some of the signs of neonatal abstinence syndrome is sneezing, excessive sucking, lots of yawning, sweating, hyperthermia, hypertonia, sometimes tremors, lots of diarrhea, excessive weight loss, vomiting. They have a very difficult time with feeding oftentimes. They get excoriating diarrhea where it just is very acidic and burns their skin. Hypertension and tachycardia. We might see tachypnea. This picture is not from the United States, so you see things spelled a little bit differently. High-pitched cry, irritability, sleep deprivation, or they can't sleep. So their little bodies are suffering as they go through that withdrawal period, and they're showing you in the ways that they can. So something called a Finnegan score or an NAS score, neonatal abstinence syndrome score, is a scoring system that we can determine how well they're managing their withdrawal symptoms and if they need help. And what we do to help them is give them usually small doses of narcotics to help them through this period and wean them slowly rather than going cold turkey. And then birth trauma This is something that physically happens to them when they are being born, either through the birth canal or through a cesarean section. And we can have fractures, we can have brachial plexus injury, which is that nerve complex here in the shoulder. We can have cranial nerve trauma, head trauma, cephalohematoma. All of these things can happen during birth. So one specific thing that I want to talk about is our brachial plexus. So this is that nerve complex that's in the shoulder or in the neck going down into the shoulder. And so if we have a baby that has a shoulder dystocia, the head has been born, but the shoulders are still up behind the bones of the pelvis, we don't ever want to pull down to try to dislodge that shoulder, because what happens is we can damage that nerve. And if that nerve is damaged, we can have a condition called Erb's palsy, which will be lifeline. So this patient obviously had a birth injury of Erb's palsy, and it looks like maybe surgery at some point to help it, but you see muscle wasting, and he has no control over this arm. So if we have a shoulder dystocia in a baby, we want to do an assessment right after delivery and document it. And we want to do the startle reflex, the Moro reflex, to see if this baby has movement in that arm. That will be a telltale sign right away and will be important documentation for later. So this baby does not have any movement in this arm, and it may be that it gets better in the next few days, or it may be that there is damage there. So we want to do a startle, and you can easily do it just by lifting their hands and then letting go of their hands. I know you've probably seen some other pictures where they do it a different way, but you just lift their hands, and then they should lift, when you drop their hands, they should have control over both of their arms. This baby does not. And then hyperbilirubinemia. I've talked about this in the last lecture, but here again, pathologic jaundice is within the first few 24 hours of life, and that's when they're in the high risk zone very quickly. It can be caused by RH incompatibility or ABO incompatibility, and we want to avoid connectress. So we want to get that jaundice level down very quickly in our pathological jaundice babies. Physiological jaundice is third to fourth day of life is when it peaks, and we will expect to see it rise, but then it not get to too high of a zone and then come down over that third to fourth day of life. Remember, lots of feeding. So just to reiterate, lots of feeding to get lots of elimination, because that's going to help us get that excess bilirubin out of the body. The bilirubin is a byproduct of all those excess red blood cells that are being broken down and creating bilirubin, and the liver is immature and is unable to keep up with the demand. So that's why you see this imbalance in rate of bilirubin production and elimination. So again, visual inspection, a really poor indication of how jaundiced someone is. It may be a good indication of if they're jaundiced, but not what the levels are. And so we're looking for those bilirubin levels, and we're going to use that Butani nomograph to determine what risk zone they are in. This is an example of a Billy light. This is a Billy blanket, and then these are lights that go overhead. These Billy blankets are what we most often see on the floors and sometimes in homes if they need an increased way of getting that bilirubin out of their body. So if their levels are getting too high and they're moving into that high risk zone, we want to get those levels down by whatever means we can. And this Billy light is a UVA light, and it will help to break it down through the skin as well. And then risk factors for increased hyperbilirubinemia. I've talked about this before. You can see deficiency of G6PD. That's a genetic difference that happens in some babies. And if there was a sibling with jaundice or anemia, or they have extreme cephalohematoma or bruising, or if there's infection, immaturity, or infant of a diabetic mother, then those are all reasons that we're going to be watching extra closely for that. And here's that Butani nomograph that I've talked about in the previous lecture. Okay, so newborn infections, they can be bacterial, fungal, viral. And again, their systems are so immature that they don't respond well. They don't have the army to mount against these things. So one of the risk factors we're looking for are non-specific symptoms. If they have decreased temp, poor feeding, if they have decreased tone, they have a mottled appearance, if they're lethargic, these are all of our, maybe have a little respiratory distress. All of these are signs that something's going on. And so most places will still draw a CBC with a manual diff. Remember, they can have WBCs up to 30,000 right after delivery, an elevated CRP, and a positive culture. So those are things that we would be looking for that would tell us there are signs of infection. If all of these things are within normal limits or slightly above normal, and they still have symptoms, they still may be treated. It will depend on the provider at looking at that specific clinical situation. Our job is to recognize that something is not within the norm and then report that so that we can look closely. Because like I said before, we want to catch these babies before they have all the red lights telling us that they're not okay. So the C-reactive protein, CRP, sometimes you'll see some facilities that don't use this. And our cultures take 24 to 48 hours for our preliminary and final results. So we can't wait that amount of time. Oftentimes, we will draw labs, start antibiotics, wait for the labs to come back and see how the baby does. And then if everything looks okay, they may or may not finish that course of antibiotics, depending on the provider, or have a shortened course. And so we have 3 different types of infection: congenital, so that happened when they were in the uterus. Early onset is in that early prenatal period, and then late onset is a couple of weeks after delivery. These are our risk factors for neonatal sepsis. Here are a few that we've talked about before: prolonged labor, a rupture of membranes. Now this resource says 12 to 18 hours, maternal urinary tract infection, substance abuse, poor nutrition, poor prenatal care. All of these increase the risk for sepsis. And then a few of the congenital conditions that we will see: neural tube defects or differences, esophageal atresia or tracheoesophageal fistula, omphalocele or gastroschisis. These are all pretty intense, big conditions that need surgical intervention for the most part, in most cases very quickly. So these babies most likely will be sent out or sent to a facility that can manage these. You might work in a facility that manages these. Imperforate anus means there's no opening, and a bladder extrophy is outside the body. So all of these are pretty severe conditions that need immediate attention. And just remember, these babies have no immune system, and even less than a newborn does. So we really recommend that they're not, once they do graduate from being in the NICU, that we are watching them very closely, making sure that no one's coming up into a store, better yet, not having them in a store at all, or, exposing them to all the different things that we have out in the world. So this is just a little sign that I was on a car seat that I thought was worth mentioning. Amazingly enough, many of these NICU babies go on to have no deficits and do really well throughout their lives. Our neonatal intensive care units have just grown by leaps and bounds in the last 20 years. I think that's it for this lecture. Thanks so much for watching.